This is It's Not In Your Head podcast with Dan and Juz. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers. Hey there, welcome to another episode of It's Not In Your Head. I'm your co-host, Justine Feitelson, here with Dr. Dan Bates. Hello, Dan.
Morning, Juz. How are you?
Good. Super psyched to go through body part pain today, finally. We spent a lot of time touching on aspects of neuropathic pain, nerve pain, right? How would you actually treat that from an algorithm perspective? We then dove into sensitization, central sensitization, and how that presents from our perspective, basically as nervous system dysfunction, but then presenting with a number of different symptom buckets, depending on what part of the nervous system is primarily affected. We've touched on and talked about different aspects of body part pain, obviously in past episodes as well. And we'll get into a lot more detail in the future under specific body parts and presentations related to nociceptive pain. But in order to do that, we're going to today go through our nociceptive pain algorithm because Dan has finally gotten many years of thinking onto one piece of paper. And it'll allow, just like we have in other episodes, whether you're typically a primary care physician or even a patient or a different type of physician who has patients presenting with nociceptive pain, to be able to look at that and more effectively and efficiently work through that. So that's what we're going to dive into today. And that will allow us to get into a number of different topics that relate under this algorithm, and in particular, circle back to and expand upon a lot of what we introduced just a little bit with our beginning episodes around central sensitization. So that's the plan for today.
Nice. Nociceptive pain is like, I think nociceptive is like one of those stupid words. Like it's so hard.
I think nociplastic. I think
nociplastic like tops it as
it
like
that's the worst.
It's a terrible word. I don't even think most of the medical world understands what it is, let alone the general public. And I think nociceptive pain kind of fits into the same bucket where you go, what the hell does nociceptive mean?
Exactly?
It's such a weird word. You know, body part pain, body part pain, body part pain. And I think that, you know, if you bust a leg, you bang your toe on something or you've got osteoarthritis, like the majority of that pain is body part pain, which if you're like being a pain doc, I suppose.
The more normal stuff.
Or in that. Yeah. Normal pain is nociceptive pain. So we will try and use the word body part pain to make it more logical for people. But, you know, you will intermittently flick in and out of the words nociceptive, which just translated in your heads to body part because that's actually what it means.
Yeah, this is not the nervous system amplified pain. That is nociplastic pain. Right? It's pain coming from body parts, nociceptive.
So clear. Anyway,
makes total sense.
I don't actually have a better way to like make it clear. But anyway, so probably listen to some other podcasts and that'll explain the confusion. Anyway, so this algorithm, I remember trying to write this algorithm down the first time in like about 2010, maybe 2011, as I was inundated at that time treating people with osteoarthritis. And this is kind of where all my sort of thinking started. And I could not write this down. Like I could not get this to lay out in an algorithm, like in something that was workable. And, you know, it's only really been after some talking with Juz over the last couple of weeks that all of a sudden it's gone, oh yeah, that goes there, that goes there, that goes there. They all work. So for anybody who's, well, if you're watching this, you'll be able to see me bring up the shared screen now so you can actually see it. And if you're not watching it, well, now I'm sharing a screen that you can't see. So
flick over to YouTube for the screen.
Yeah.
Or the website.
So what we're going to do is just briefly roll through this algorithm and how you think through it. It's not actually laid out in the same order that I think about it normally, just in the way that I describe it. So we jump around a little bit, but it's laid out in a way that makes it fit onto a page and makes sense. We've also laid it out in the same framework as our central sensitization algorithm. And we're about to redo the neuropathic pain algorithm, sort of bring it into the same structure. So we're starting to get everything sort of flowing together.
Standardized.
Yeah. And that structure is one of, you know, seeing somebody who presents with prolonged pain, and then there's assessment, you know, first line investigation, first line management, which is generally all conservative stuff, second line investigation, and then referral strategies and who you refer these things out to. And if you're a patient, who you should be thinking about going to see if you haven't really responded to the conservative management options. So, all right, here we go. Thinking through this. So basically there we go. Body part pain, or when you've got someone who's presented with prolonged pain, we're basically thinking about it once again as splitting into three main components. So have they got neuropathic pain? So neuropathic pain is burning, pins and needles, numbness, itching, crawling, painful cold, painful squeezing, electric shocks, and just a deep ache. Have they got nociceptive pain or body part pain, which we'll dip into further? And then are they centrally sensitized? And so central sensitization is, it either feels like neuropathic pain or body pain. It goes from being focal to it spreads. It goes from being intermittent to constant. It goes from being proportional to disproportional. So little injury, little pain, big injury, big pain. And it goes from having specific things that make it better and worse into everything just makes it worse. And so this central amplification also comes with the amplification of other things. So you get amplification of other senses. So you get amplification of light, sound, smell, touch, taste, heat, cold, balance sensation. You then get your sleep disturbance, your cognitive dysfunction, your mood disturbance, your dysautonomias, your fatigue, and your motor dysfunction. And within that is where nociplastic pain sits. And so that's the amplification of pain by the central nervous system, which has its own set of mechanisms. But the way we think about it is that amplification of pain is just one component of thing that's being amplified. You're also getting other stuff that's getting amplified. And so you've then got, nervous system dysfunction rather than just focusing on pain as the major presentation. All right. So back within that comes nociceptive pain or body part pain. So body part pain is split into two components. So it's split into somatic pain, which is once again another technical term, but basically it's musculoskeletal pain. So it's arm, legs, back, etc. And then you've got visceral pain. So visceral pain is the pain that arises from your organs, and such as, heart pain, gastrointestinal pain, pain that comes from your bladder, pain that arises from liver and those sort of structures. And so with visceral pain, it tends to be, it'll be a deep ache. It tends to refer. It can be what we call as colicky. So it comes in waves and goes away, it comes in waves and goes away. And most importantly about it, it's not particularly focal. So it's a very diffuse pain.
It's not localized.
It's not localized. And the thing with when you think about arms, legs, and backs is that arm, legs, and backs, easiest way to think about it is when you stub your toe, there's not just a pain signal that goes up to your brain. There is also pressure, touch, vibration, etc. that goes through, which are much better mapped in your brain. So your brain will get this signal that is like ouch.
Specific.
Yeah. So this is the nociceptive signal. So once it's nociception all the way up until you get to perception, which then when it's perceived is then cause pain. So that's why you get this nociceptive pain algorithm, basically. So you get this pain signal or this nociceptive signal going up to the brain with vibration, and touch and other information, and your brain puts it all together and goes, my big toe hurts. Where what's happening with visceral pain is you don't have touch, vibration, and light, etc. So there's nothing that allows you to be able to localize it. So your brain gets a signal that is converted to pain and goes, somewhere here.
So it's like
about here, something hurts.
Right.
And so as a result, it becomes more diffuse.
Yeah. And that can be right. I mean, you hear horror stories of like lung cancer patients that had broad, diffuse, pain for a lot of years. It was hard to pin down. They thought it was a bunch of other things, and it turned out to be something serious. So visceral pain can be harder to catch and diagnose sometimes compared to some of the somatic ways that.
And it's difficult. It's difficult. So
somatic pain is far more common under that nociceptive bucket. So why does visceral pain also get missed or harder to diagnose? People see it less. It's less common compared to, so you're used to seeing musculoskeletal pain come in your office.
Because
far more common.
Just like all the stats, the way it fits together. So 20% of the world suffers chronic pain. So of that, 70% is lower back pain. The next 20% is osteoarthritis. The next 8% is neuropathic pain. And then the last 2% is kind of everything else. And so,
all you complex sensitized folks, raise your hand.
Yeah.
That's
And
us.
so we end up seeing lots of back pain and osteoarthritis. But the majority of pain we see is body part pain or nociceptive.
So then if you put then visceral to the side.
Yeah, put visceral to the side because we're not going to focus on that today. We're just going to really focus on nociceptive pain in the construct of effectively musculoskeletal pain.
Right.
And so that pain is generally presents as it's an ache, sharp, dull, pressure. It tends to be focal, it tends to be intermittent, and it tends to be proportional. So little injury, little pain, big injury, big pain.
Which
and it has
sense,
specific things that make it better and specific things that make it worse. And so within that comes all our questions around when we're asking patients what makes it better, what makes it worse, does it hurt when you bend forward, does it hurt when you bend back, does it hurt when you stand, your hands hurt when you sit, go from sit to stand, roll over in bed, all those sort of things. All those things indicate different sources of pain. And so they're what we are, we're looking for actual structures that present in a specific way. And so overarching wise, that is how nociceptive pain will present.
Well, and you'll have these same nociceptive drivers or issues in someone who has central sensitization or other neuropathic drivers. So it can be tricky and harder to tease out some of these body part drivers the more complicated it becomes, but they're still there. And those patients aren't less prone to them.
So after that, you can then split your body part pain up into mechanical pain, inflammatory pain, myofascial pain, bony pain, and then vascular pain. And we'll just sort of talk through each one of those so that you're starting to get a bit of a sense. And this is where I'm starting to tease out. And my history when I'm taking it encompasses, components of all this sort of stuff. So with mechanical pain, what I'm looking for is I'll be asking, do you have any painful clicking, clunking, or instability? Interestingly, depending on the culture somebody's from, you have to ask the words, does it make a sound? That's the other way to do. Interesting, I think, within the Greek population, if you ask painful clicking or clunking, no idea. If you ask, does it make a sound? Then they answer it. So you've got to be able to change things. So if you're thinking about it from a doctor or clinician perspective, just as an aside, they like being able to change pins and needles doesn't make sense within a neuropathic pain. You have to use the word tingling with other cultures, so they understand that. The other piece is then, so clicking, clunking, and is it painful? So within that setting, I'll be looking to see if something is painful. You get lots of clicking and clunking across various joints. A lot of the time it'll make people feel better for whatever reasons. But the question is it painful? Because in that setting, you're looking for tendons that are flicking over bones. You're looking for loose bodies. You're looking for torn cartilages that need to be addressed. The other component is then instability. And instability, put down simply, you can split into two components. One is ligament insufficiency, whether that be an acute ligament insufficiency, which means you've torn it, or whether that be a chronic state where it's torn and healed long, or you are hypermobile or have one of the hypermobile disorders within the EDS bucket, and so you are stretchy. So that leads off into like a whole other world. And then the other component is then neuromuscular dysfunction. And once again,
which is also its whole other world.
Which has its whole other world. And I think that once again, you get an acute setting in that. So the acute setting is where I refer to it as pseudo inhibition. So what you get is you get a pain signal and then say your quads turn off. So people will describe that as, my knee just gave out. And so in that setting, there's not a ligament laxity or a ligament tear as such, but what happened is that you have pain and then your body then protects the joint and turns off the muscle, and so it gives way. And so it feels like it's unstable, but it's not. It's pseudo instability. And so that's like the acute setting. And then you've got the long-term setting where what you've then got is you've got muscle wasting, fatty infiltration of that muscle, or you've just got altered patterning of that muscle. So it's just, you're not getting appropriate firing of muscles in the correct sequence. And so that results in instability of the joint.
And long-term work around painful areas.
is something we'll probably, like, those two concepts will come to at another.
It's hard for me to be quiet right now.
I know, like, just like,
oh my God.
like just my thing. I want to talk more about it. But
no. Be quiet. Yeah. This is my thing. These two buckets is my thing from a movement perspective. It's fascinating. But we'll keep it going for today.
We'll just keep it moving. Okay, so moving on from that, we're then talking about inflammatory pain. So inflammatory pain presents as it's worse in the morning, improves your warm up, worse cool down, associated with stiffness, goes away a little bit with anti-inflammatories. In the acute setting, it's generally associated with redness, swelling, stiffness. So, if you've injured something, gets red, swells up, blah, blah, blah. Over the longer term, yes, it may be associated with swelling in the area, but a lot of the time that just goes away and you don't get the swelling. Certainly some inflammatory disorders will last and give you a certain degree of swelling. They'll come, they'll go, they'll come, they'll go. Within this setting, when I'm talking to somebody within a history, I'm basically looking to see what's happening for them in the morning. So is it, better, worse, no different? How long does it last? And that's really the key factor within this. Well, there's two key factors. Number one, how long does it last? Is it 10 minutes? Is it 30 minutes? So in that sort of setting, I'm thinking, this is osteoarthritis or those sort of disorders. Once you get over 60 minutes, the likelihood the patient has a inflammatory disorder, so we're now getting into rheumatoid arthritis, psoriatic arthritis, or your gastrointestinal related arthropathies, your spondyloarthropathies. Now we're starting to go, okay, now I'm thinking about talking to my friendly neighborhood rheumatologist and getting them to provide an opinion in that sort of setting. So the other thing that I'm thinking about with inflammatory pain is what is the dominant feature? So in the morning, what's worse? Is it the pain or is it stiffness? So when someone's complaining about stiffness being the primary issue, okay, I'm now wandering down the track of thinking this is an inflammatory disorder. And once again, you get to go see, the friendly neighborhood rheumatologist to give us an opinion. Your next component of pain I then think about in that setting is myofascial pain. So myofascial pain presents as muscle tightness and trigger points. Trigger points are focal areas of sensitivity within muscle. Like my mum would have called it a knot. Darren, you got a knot in this?
Yeah.
Massage it out. And, Juz and I were talking about this over the last couple of days of getting into the concepts of myofascial tone.
It's another rabbit hole, black hole.
God. This is,
it's fascinating because it ties in very closely with the instability and the nuance around that. And when is myofascial pain or changes a result of things, and when does it become a bit of a dysfunction in and of itself that then creates other issues? And so we'll dive into this bucket too. I'm zipping my mouth off on this one also because it's fascinating, but it's complicated. So,
and I think what's interesting here is that when I see a patient, I'm not seeing them because of someone who's presented dominantly with myofascial pain, because
it's other
that
stuff
gets treated before you see me. So my experience of myofascial pain is it's generally
a result
in my consult room, secondary. You have a underlying injury and you have secondary myofascial pain, where everybody else who's got myofascial pain and trigger points that are the primary issue, well, you generally don't get to me. Somebody else has sorted it out. So bony pain. So bone pain is pain that arises from bones. It gives you pain on impact, such as when you push on it, it gives you pain on weight bearing. And it also can wake you in the middle of the night. So the components of this, so my experience with bony pain is two main areas. Number one, stress fractures. Within the sporting area, as you gradually load something, if you overload and you go too quickly, you basically exceed what the bone's capable of responding to, and it starts to break down. And so that's when you start getting stress fractures. And interestingly, when they are particularly bad, they do wake patients in the middle of the night. The other thing that bony pain will wake people in the middle of the night is when it's cancer pain. And so this fits under the world's red flags. And so pain that wakes you in the middle of the night is a red flag that you need to go searching for and make sure that that's not a bony metastasis, which is a spreading of cancer to the bones. And so they're the things that we are thinking about when you're thinking about bony pain. The last piece within nociceptive pain or body part pain is then vascular pain. So vascular pain, it tends to be very much a deep ache. It comes on when you exercise and it goes away relatively quickly at rest. And ironically, so this is the part of body part pain that I don't see very often because it generally, once again, gets picked up by somebody else. And
it's its own niche.
PCPs or general practitioners will go, well, that's not a Dan problem. That's a vascular problem. So they flick them off. So I don't see it very often.
I saw a vascular surgeon before I ended up in pain management for CRPS, I think, on the diagnostic journey.
Yeah, because everyone's working through not that.
Yep.
And so I don't see it very often. Now, that said, I saw it last week, actually. And then I had a patient referred to me for back pain, and she certainly had elements of back pain. So had pain in the back, going down the legs. Pain was worse in the legs than the back. And the thing was, when you start going, well, it goes away 100% when she's sitting down. And I was like, okay.
Which is unusual with back pain alone.
And then on examination, could find nothing, couldn't reproduce the pain. And the distribution of pain was different. Yes, down the back of the legs, but as they started walking, it extended down over her thighs. And I was like, yeah, okay, this does not match the patterns it should. And, because I don't see this all the time, I don't automatically go, oh, boom, this is
right. You're excluding things to get
I go, this is vascular pain. And it takes me time to get there. And it was only when I pulled up the MRI that I was able to see, okay, we've got a large amount of calcification taking place through aorta and femoral arteries, which don't see very often. So I've gone, okay, let's exclude this. So they're off to the friendly neighborhood vascular surgeon. Yeah. So
everyone Dan refers to is very friendly.
I try to use friendly people.
Yeah.
I kind of tend to go red. I think that most of the time you can be really good at your job and nice.
Yeah, it can still be kind.
You don't have to be grumpy and really good at your job. That's a whole other discussion. Anyway, moving on.
Dan's never grumpy.
Unfortunately, Dan does get grumpy.
It's the frown.
When my cognitive dysfunction happens. Okay.
Yeah.
When I'm sitting there going, I don't understand what's going on, and I start to frown. Yeah, pretty much. That's it.
Patient gets worried.
Patient gets worried. Like me. Sorry for all the frowning to all my patients.
Ends in something good.
Oh, okay. Yeah, most of the time, hopefully. Okay, so once you've sort of worked through, and I think that once again, the whole idea with thinking about things in an algorithmic perspective is that even though you may not know what is going on for the patient, you can actually pick, what do I need to do next?
Right.
And you can pick what is your first line therapy to be able to sort of manage this while you work it out.
Right. Okay? It gives you a higher likelihood positive step.
Yeah. Diagnosis is not necessary to be able to treat the pain. And I think it's interesting. I recognized when I switched to doing this is like 2000 and probably sometime around 11-ish when I started thinking about this, where I started recognizing I was more thinking about what type of pain has the patient got rather than what the actual problem was. And so I then just start managing the pain while I looked for what the cause was.
Right.
And it started to open up additional options rather than sitting there going, I don't know what's causing this. I can't do anything.
You're just
I was able to go, this is body part pain or nociceptive pain, and they've got an inflammatory component. Okay, I'm going to start with managing with some anti-inflammatories and some blah. And that's sort of how it sort of starts to pan out.
It's way easier to nail down the type of pain than the specific exact diagnosis. There's 3 types of pain. There's a bajillion pathologies. So at least if you're working within the right type, yes, I love that because then you're improving while you're figuring more out.
Yeah. So while you're figuring it out, you can manage
it. Which is reasonable. Yeah, it's reasonable.
Yeah. And so then we step into first-line management. So first-line management within this is then as indicated by what's going on. So it may be X-ray, it might be CT, it might be ultrasound. Certainly with bloods, if you've got an inflammatory component to it that you want to exclude, and sort of that's really where you get your simple blood tests, full blood count, and then you're looking at maybe just CRP, which is an acute inflammatory marker, and an ESR, which is a long-term inflammatory marker. When I first got taught about what ESR meant, I can't remember who taught it to me. One of my professors said, just look at the last 2 letters, SR, something's wrong. That's it. That's how non-specific it is. Something's wrong.
That's great.
That's pretty much still the way I look at it. If you've got to raise ESR, something's wrong, got to go find out. And then within this, particularly if the patient's presenting with vascular type pain, you go into a Doppler ultrasound to look at vascular flow. And that can be, that gets you very quickly to where you need to go. From a management perspective, you're tying in a referral to allied health. And that's where you're automatically starting on, working on your rehab. I think at this setting as well, even though I might not have a diagnosis, you can be starting to look at minimizing your losses.
Stop the bleeding, like start going in the right
Yeah, stop the muscle wasting,
direction.
stop the alteration in motor patterning, utilize allied health skill around deloading. So you can deload, you can use your exercise physiologist as well to minimize your deconditioning. So that's one of the major things that happens. Someone gets pain and then they'll go, just rest. Okay, great. Rest is a component, but sometimes you can just rest the body part and you can continue your conditioning. So you minimize how much, you
work around the limb.
You work around it.
And then you bring it along, once you can, or the body part area.
So I've got my little rehab thing set up. And so the way we work around that is we've got both upper limb cardiovascular exercise stuff. So we've got an upper limb grinder and we've got
it's like
ergo.
Yeah.
And then if you can't weight bear, we've got a seated bike so you can offload. And then for people who've got upper limb stuff, well, you can, if you can't sit on the bike, you can walk. So we've got treadmills, et cetera, et cetera. So what you're doing there is you've got multiple different ways that you can maintain your conditioning as much as possible while you're working out and while you're treating stuff. Deloading within the area of bone pain is really important. Having structures where you can deload. And interestingly, deloading where you've got stress fractures sometimes comes down to putting people in a wheelchair, which I've done before, particularly with sacral insufficiency fractures. Sacral insufficiency fractures you see in older patients that have got osteoporosis, and they are absolute agony. Like the patient, and interestingly, the patient sits down, 0 pain, stands up, 10 out of 10.
Yeah.
And they get quite, because you can't see them on X-ray. You can only really see them on bone scan and MRI. So they're very hard to pick. But the key diagnostic thing, I think, is that 0 pain when sitting, agony when standing.
Yeah, that's a dramatic.
And when you push on it, so pain on impact, which includes pain on just palpation, the patient does not like you when you palpate through over their sacrum. And so it's a very... it's very sore. But those patients, sometimes you just have to chuck them in a wheelchair and to deload them enough to be able to have it heal. With myofascial pain, the patient that comes in is really, that can be about down-regulating. That can be including massage, dry needling, wet needling in certain circumstances. And now we're getting to Juzz's area, but, I think that, so a lot of muscle myofascial pain arises due to weakness. So
even for me,
doing a strength program, which seems counterintuitive in some circumstances, but getting stronger, which means that the muscle is, more capable of managing or dealing with the load. So it doesn't have to spasm.
Yeah, it's spasming because other areas can't kick in and engage, right? So as you get more inhibition, then it starts to change that balance. And maybe strength program isn't even for someone the right word. It might be stability program. And then you're progressing from stability into more load. So it's wherever you're at, just stopping that bleeding like Dan talked about of the inhibition, weakness, spasticity cycle.
Now, one little useful thing within this, and this is where I see patients, so one of the things that I see is that when someone goes to see the physio, the myo, the whoever, and they get some release work, so they relax all the muscles, they dry needle in them, and what happens afterwards is they get a massive flare of pain afterwards.
Yep. This has happened to me too, post-massage, like a ton of, pelvic release. That's the only thing holding me together.
Exactly. And so in that setting, so that for me is an indicator the patient has ligament insufficiency. And so what's happened is that the patient's muscle tightness is holding them together. You release that out, everything then moves. Your body's response to things moving the way it doesn't like them to move, such as sacroiliac joints, is that it then spasms around, and when it spasms, it can get massively out of control. The patient can have an enormous amount of pain. They turn up to the emergency department. Nothing touches the pain.
And it's like widespread. It's amplified. Yeah.
Nothing. They get a scan. Scan looks 100% normal. And so the resultant effect is it's in the patient's head.
It's in your head, right.
They're a drug seeker. And
they're a baby, right.
And they get kicked out. So if you're a clinician and you see the patient, like you've seen the patient, released everything out, or you've seen somebody that's been released out and they spasm afterwards, that's where you start thinking about ligament insufficiency, and that's the diagnostic line. And so for me, that's what people come to me for. And so one of my key questions within history is, does your physio make you worse?
Do you get worse? Or does your massage therapist make you worse?
And interestingly, the physios and a lot of the allied health people, they don't see this pathology, because what happens is the patient sees them once, they get worse, and they never go back.
Yeah.
And so it's not a pathology that presents to allied health professionals. It's a pathology that happens
after the fact.
And so, and they're like, oh, the physio made me worse. And I'm like, well, it's not the physio's fault.
Well, there could be other things too.
What's going on underneath. So that is one thing to sort of pick up.
Well, and it's a big asterisk then, right, in the hypermobile population. And this is why I'm cautious when I don't love the term either self-administered release techniques, because you're really not releasing anything, but you don't just want to do release techniques and then not complement it with the appropriate stability, because even in that setting, you're just increasing the lengthening and not complementing it with the accompanying activation you need. So
good.
Beware.
I liked that. Well, I haven't thought about it in that concept before. We should podcast on that.
Oh my God, we should. Okay, moving right along.
Moving on. Okay, so inflammatory pain, looking at anti-inflammatories in like standard NSAIDs, corticosteroids can have their role within this environment, bearing in mind things like prednisone, catabolic. So for patients with osteoporosis, that's not great. For patients with hypermobility, the catabolic nature of corticosteroids means that they break down more collagen. Certainly, cortisone injections around tendons and ligaments, pretty much look at the data now. And this came about really when we were starting to look at platelet-rich plasma with comparison to cortisone, is that patients that get a cortisone injection over a tendon are worse at 6 months than you would be if you did nothing. So
cortisone has not supported anymore.
So I've sort of moved away a lot from the use of cortisone, and these days use it more as if you have an acute flare and you've got to turn it off, it is the thing to use. It is fantastic. I think it still plays a role in when I'm managing neuropathic components of pain, but, osteoarthritis, I avoid sticking it in OA joints all the time.
Different upside downside risk reward.
Now that all changes like once you move into the world of inflammatory disorders, and so your rheumatologist is saying, well, we need to go down the track of looking at some prednisone. Well, that's a whole different world.
It's a different story. Yeah.
Within that bucket, you've got your natural anti-inflammatories, your curcumins, your the never-ending list of stuff. I think that we should sort of sit down and there's an entire podcast where we could sit down and look at anti-inflammatory supplements.
Oh, yeah. I was going to say, I think we touched on some of these even in the neuropathic pain algorithm a tiny bit.
But I think that they do have a role, but you got to treat them like any other medication. You try them. If they are effective, great. If they're ineffective, you chuck them out and try something else. The next piece is then if you then look at, what's your next line? So you've sort of seen the patient, you've started off your initial investigations, you've started off some conservative management strategies and then reviewed the patient. They're not getting better. That's when you're setting your second line investigations, which may be MRIs, bone scans, SPECTs. We're using more SPECT these days. So a SPECT scan is where you do a bone scan and a CT scan at the same time, and you then overlay the result, overlay them on top of each other. So a bone scan shows increased bone activity. So it particularly shows the activity of a set of cells called osteoblasts, where you're getting the increase in bone being laid down. And when you then put them on top of a CT, you can then clearly identify what structure is turning over. And that becomes very useful.
That's cool. It was just a plain bone scan that diagnosed my CRPS.
Yeah, bones.
So that's really interesting. Yeah.
So a plain bone scan is, kind of fuzzy medicine. It used to be called nuclear medicine.
That is what it's still called.
Fuzzy medicine, because everything's fuzzy and it's kind of there. With a SPECT CT, it allows you to better localize stuff. It's quite useful within the body part environment. Just because it lights up, once again, doesn't mean it's the source of pain. And so in many cases, I'll go on to do, depending on what it is, a diagnostic block to confirm that that's what's causing the pain. But that's where you're getting into specialist referral. And so, obviously with your inflammatory disorders, you're flicking them off to your rheumatologist. With your bony disorders, if you've got osteoporosis within the patient, you're then going to be including the endocrinologist. If you've got a stress fracture environment, you might involve a sports medicine physician. So, they do have an additional expertise around how you manage that stuff. And I think, at that level, also involving a dietitian, because a lot of the time...
I like that's in there.
This has got to do with, eating, and it might...
There's a metabolic piece.
There is a metabolic piece within this, and that might be that there might be calcium intake, but it also might be just total calorie intake, which is particularly within the exercising female population. There's a thing called relative energy deficiency in sport, which is REDS. It is, where you are not taking in enough calories and you get a whole stack of secondary metabolic things, of which osteoporosis and bone stress present within that population.
So it's a younger population.
It's a younger population.
To have a dietitian, right? Then, for example, someone who is not even necessarily older, but it's the complement to that deconditioning, atrophy, sedentary piece. Your diet often accompanies that.
Look, and I think obviously within the osteoporosis environment, there's role for involving the dietitian, which we'll get into a conversation with an endocrinologist one day about management of osteoporosis. It's sort of like in Australia, the funding model that we have doesn't really make sense to me, but it'd be interesting to talk to somebody else about that. Other specialist referrals, this is really... this part of the algorithm's telling PCPs and general practitioners how to suck eggs because they know how to do this. This is like their expertise.
Right.
You've got this.
Go here, go there. It's a traffic conductor.
Go there. This is the person that you need.
Your PCP will hook you up.
Yeah. Not only do I find that PCPs, general practitioners, they refer appropriately, but they also refer a lot of the time the right patient to the right person. They have multiple different options that they can choose. They may choose a skill base and a personality type that they send to people. In this part of the algorithm, I apologize for telling my GP friends how to suck eggs, but
how to already do their job.
Yeah. And then at the last bit of then is when the patient comes back, we're then reviewing and assessing responses. We had talked about whether we put in under this component, this is the back pain algorithm, this is the shoulder pain algorithm, knee pain algorithm, it'll probably come in at a later point in time. But right now, it's about reviewing the patient, reassessing, see where the responses and changes have taken place, and then managing. Yeah,
this is more of a global body part pain perspective. Yeah. And then you can get into more specific trees under location. Cool.
So that is 14 years of my thinking of how to pull it together.
I brought us home.
You did. You know what the thing that brought it together was?
I like to think of myself as the spark.
You know what it was? It was the instability piece. It was the being able to sort of split that into...
Yeah, pull that shit out. It's because it's a part of everything else. And then it makes everything so hard to see because it overlaps all over.
Yes.
So yes, we acknowledge that that's a big piece of all the other things. But yeah, that's what helped.
Yeah, so that made it all fall into place. So there you go.
Yeah. Now it's done.
So
for now.
All right.
We will likely, we'll keep updating this algorithm over time, just like we have and will the sensitization one. Dan already mentioned the neuropathic one is already the tunnel to version 2. So yeah, we'll keep circling back to this. And like I said at the beginning, we will now start to dig into some of the different buckets of sensitization and specific pathologies like POTS or whatever it may be under the buckets that you present primarily with, and cover those from a more conservative and then also from a specialist perspective, where it won't just be Dan and I that you always hear our sides from, but we'll start to bring in other experts to dive in deeper into some of those specific pathologies around and within the context that we're looking at things from, with how we've defined nervous system dysfunction and the myriad of ways that that presents, whether you are a highly sensitized patient or just have a couple or some of those pieces. And maybe you are more nociceptive, right? Maybe you're more neuropathic without the amplification, but it will still overlap and apply, because this stuff affects a lot of patients and populations who don't realize that it's sensitization related or that that's a piece of it. So
yeah, this will be
just fun is just beginning. So we had to get this nociceptive algorithm.
You are such a nerd, I swear. Anyway.
I'm very cool. You're the
Next
bigger nerd
in
than
your
me.
sensitization fun.
Saturday afternoons recording. Yeah. I love it. But yeah, so we have a lot to dig into. And now all these 3 algorithms are out there. We've also updated a ton of information on our website. So now there is written summaries essentially for every episode, so that it's not just auditory, and you can go back. And it's because when I talk to my own patients, they're like, yeah, they're taking notes on the episodes, right? And while that's awesome, we want to make that a little bit easier for you and have essentially provided that for you. So you can always circle back to the website now after episodes to get additional information and have an easier time than integrating what we talk about. All right.
Well, awesome us.
Awesome us. Yeah.
Well,
good job, Dan.
You, because you actually did the majority of that work. So thanks, Joe.
Thanks. I try. All right.
All right, we're done.
Thank you. We will see you next time on It's Not in Your Head.
Thanks for listening. Clearly, this is a podcast. It's for informational purposes. It's not a consult, medical advice, or the practice of medicine, and it doesn't form a therapeutic relationship. If you feel the information might be useful for your situation, before applying it to yourself or others, you should speak with your doctor or your treating clinician. Do not delay in seeking a diagnosis or treatment, and applying the information is at the listener's own risk.